Thanks, Dr. Amit, and at least we could find some audience here in the last session of this, and it is very enthusiastic for me also. So my topic is perfecting toric oil implantation technique. I have no financial disclosure. As you know that modern cataract surgery is more of a refractive surgery, and myopia and hypermetria can be corrected using appropriate spherical power of the lens, but there is a 20% of patients who undergo cataract surgery have more than 1.25 diopter of corneal astigmatism, which is visually significant after the surgery, and they are very unsatisfied if you don't correct them. And the best way to correct is by implantation of the toric IOL. So, how to achieve the perfect result? Technology and surgeon technique and combination of both surgeon and technology achieves the best results and best outcome. Now coming to the what are the prerequisites for the toric IOL, and good central capture axis is very important in these cases to remain the lens into center for the longer duration, longer times. Precise keratometry is again very important. If you don't do keratometry properly, then you will have the suboptimal results. Accurate biometry is again important. If you have done the beautiful implanted the toric IOL, but your biometry is not good, so again it is a source of the dissatisfaction to the patient. And you must know what is your surgically induced astigmatism, because while making calculation for the making calculation, you must incorporate your surgically induced astigmatism to have a better outcome. There have been a certain IOL make and material which have effect on rotational stability of the IOL. So we'll be coming on the later. Material of IOL is important, and marking axis is very important. You have to mark the axis perfectly, and you can use various methods for marking, and you can have a markerless viewing system, visual system. Size is important because if you have a perfect axis, and it should be not more than 5.5, maybe slightly smaller axis is preferable in these cases, and it should be central. If you make a small axis, you will end up with this kind of the picture, and that will lead to decentration of the IOL, and you have to do additional acting. This is the perfect axis up to the 5 mm. 5.25, 5.5, it is perfect, and the IOL should be covered at most 0.5 mm on the optic of the IOL. So it keeps in the bag all the time. You can, for the axis, you can use your simple corneal marker with the metal marker on the cornea. You can just touch it, or you can use this markerless Callisto system, which I have been using. So guide for the perfect axis and sizing of the axis. So you can use this better. So this is very important step while doing toric IOL implantation. Now, accurate keratometry, how to obtain accurate keratometry? You can have manual, automated, and corneal topography also. Most of the surgeons use the amount of astigmatism with the one machine like IOL Master, and for the axis they use the corneal topography. And if you are not obtaining the good result with the keratometer, then you can use corneal topography for the obtaining the accurate keratometry. K reading for all three, so high repeatability and are comparable. Manual keratometer should be calibrated regularly. It should keep in mind that it should not be recalibrated, and corneal topography is required in cases of unusual reading and poor quality of eyes. Precaution must be taken that reading must be quick to avoid corneal drying, because most of the machine uses the tear film for the obtaining the keratometry values. Don't rub the cornea beforehand. Centration must be proper to obtain the best result. Accurate biometry, I used best immersion technique gives the best results, and optical biometry both are equally comparable. But a scan using have lots of sometimes having a problem in accuracy of the biometry. Depends upon the surgeons and the person who have been doing a scan. So far as for calculation formula is concerned, best is Barrett suits, which I have been doing since last many years, and you must know how to calculate the surgically induced astigmatism. As you know that every incision changes the cornea, closer to the center and larger the incision, more effect on the corneal curvature. Other factors also affect like corneal age and suture. In addition, there is a variability from the patient to patient, and overall effect can be summed up into vector analysis later on. To obtain a surgical induced astigmatism, there is a calculator available. Fill it for 20 to 30 cases minimum, and you just click on, and that gives you the precise about the axis and the incision. So this is the data input. You can, in the IOL calculator online available, you can enter the data, patient data, keratometry, IOL, spherical power, surgical astigmatism, and incision location, and by this is the output screen. This guide where to place the incision and where to place the axis of the IOL. Rotational stability is very important factor. It depends upon the surgical technique. If you are having good axis and all, then there is a chances of having rotation is less, apart from the other factors. IOL material and design is important because material like silicone IOLs have less stable than the acrylic material, and the open loop haptic is slightly less stable than the closed loop like plate haptics are. So the design is important. Placement of IOL in the bag is important, otherwise you will have different results. Axial length is important. If you are having a high axial length, there is a big bag and also there is a chances of rotational problem. Orientation of IOL in the bag is also important. Like suppose if you are, whether we are implanting which axis, like 180 degree or 90 degree or any other vertical or horizontal. If you are implanting on the horizontal, there is a less chances of rotational than the comparable to the vertical orientation of the IOL. And if different IOL behave differently, some IOL tend to rotate anti-clockwise, some IOL tend to rotate clockwise from the vertical orientation. So this, you have to take consideration into the. And now coming to the intraocular pressure, you keep your intraocular pressure at optimum level. If you overinflate, then there is a capsular bag enhancement. Removal of viscoelastics is very important, and you must remove from the posterior aspect after the implantation, after the placement of the IOL. Or you can use hydroimplantation technique like this here after implantation. So you don't have to remove the viscoelastics from the bag, and just you can align with the axis marker projected from the microscope. Material is important, as I previously told. Rotational stability I have already told. Marking, you can use bubble marker, which I used, and marking should be perfect, and it should not be fudged out margin. Gravity mark is also available, so I have not used till now. Reference marking should be done to mark the 180 degree and 90, and for before the marking, the dry conductor should be dry. Enhance the marking at 309 close position. Apply marks with twisting action, and it lasts throughout the surgery. This is the marking, just a couple of minutes. If you mark this type of, this is a manual marker. First you have to mark the preoperative axis marker, then on the table you have to mark the axis of implantation. But the marking should be precise, otherwise you will have a problem in aligning the axis. Or you can use markerless, which I have already shown there, previous slides. Rotational stability, already talked about it, and intraocular pressure, like post-operative hypertony plays important role in misalignment or rotation of the toric IOL, and it occurs within first hour of the surgery. So always check the target axis after 1 hour, and corrected measures should be done. Too wound tight and too leaky wound lead to increased IOP and the bag inflation and collapse of the capsular bag, leading to the rotation. So try to remain within the physiologic IOL. Residual astigmatism, important point. For every degree of rotation, there is a 3.3% loss of correction, and 30 degree rotation almost equal to a spherical IOL. So it should not be, if it is more than 30 degree, you are going to induce the astigmatism in the opposite direction. rotate the IOL if residual astigmatism is 0.5 diopter or less than 10 degree, no intervention. If it is not required if it is less than 10 degree. If it is more than 10 degrees, simply mark the target axis on the slit lamp and rotate, or use online calculator. You enter your data, current manifest refraction, astigmatic magnitude, and IOP axis, and then calculate where to rotate in which side. So, in conclusion, center axis, a smooth axis, and thorough removal viscoelastic from the anterior capsule under surface of the IOL. Preferably 2 incisions, side port and main incision, to prevent the collapse. After alignment, prevent collapse of the eyes anterior chamber. Always 2-3 degrees short of the desired axis, so you can rotate later on. So meticulous wound construction, well-centered, smooth, adequate size capsulotomy. Positioning of the IOL on the target axis should be there, and aim for tightly loaded, not high IOP. Thank you for patient learning. I take the liberty because the speakers are less. Thank you.
Thank you, sir, for excellent presentation, and you have rightly pointed out the importance of marking and removal of residual viscoelastic. Residual viscoelastic is one of the important factor for rotation, especially in early post-operative period. So
Yeah.
it should be removed. Another thing I want to emphasize that even if surgery is done in topical anesthesia, for first 1 hour or 2 hour it should be patched, because most of the rotation occurs in early within 1 hour or 2 hours, so it should be patched.
Yeah.
Thank you, sir.
Rightly pointed out, Dr. Thank you.
Due to eye movement, basically there is chances of rotation. So, yeah.
And residual viscoelastics behind the lens may lead to also eye rotation. There is some tendency to rotate. There are various factors which I have described, that high IOP, increased bag, axial length is more than chances. So better to check after 1 hour first of the time. So
After implanting the toric lens, do you usually press it against the posterior capsule to prevent PCO?
no, I don't do like that,
Okay.
ma'am. So
And any have you seen any posterior capsule opacification after toric implantation?
till now I am yet to see.
Yet
That
to see.
I don't know why it is not occurring there. So till now I don't have
It depends
any
on IOL
experience.
factors also.
IOL
Yeah, because most of the time I use I only use the one brand of oil.
Right.
So I don't believe other brands of oil will gain the same result. So, and itself this material is very known for
Less
not to quote unofficially that
Yeah, yeah.
Alcon I use the most of the time.
Thank you. Thank you.
Thank you.